Hello and welcome. Thank you so much for joining Global Liver Institute's Innovating and Advancing Research in Liver Cancer webinar. I am Sarah Maines, the Liver Cancers Program Director at GLI, and I have the privilege of being your host today. Thank you so much for being here. First, I would like to share some brief information about GLI and then introduce you to today's webinar. Founded by Donna Cryer in response to her own experiences as a liver patient, Global Liver Institute aims to fill the gaps in patient advocacy for those living with or impacted by liver disease and liver cancers. GLI does this through a number of collaborative efforts that convene all stakeholders in the area of liver diseases, cancer, policy, patient advocacy, and more. As a patient-led and patient-driven organization, GLI holds the patient voice at the center of all we do to improve the lives of those affected by liver disease and liver cancers. At GLI, we truly believe it all starts with the patient. Additionally, GLI's Liver Cancers Department has its own website, Liver Central, which can be found at livercentral.org. This website serves as a robust online resource where clinicians, researchers, and advocates can find up-to-date resources for liver cancers education. Please also visit Global Liver Institute's website, globalliver.org, to learn about the many ways to be involved and get involved with us. Over the next 2 hours, we have an incredible lineup of speakers who will define and highlight the ways in which the field of liver cancer is rising to meet the needs and challenges of those living with liver cancers. We will focus on lessons learned from other disease states, non-invasive cancer screening options, elevating the patient story, and highlighting current evidence-based research. Our goal today is to empower you, our esteemed audience, with valuable knowledge that you can apply to both your personal and professional lives. Before we dive into our first session, I want to extend a heartfelt gratitude to our generous sponsor, ASI, and the entire organizing team at GLI who has worked hard to make this virtual webinar a reality. And of course, a big thanks to all of you, our audience, for joining us today. Now, let's get ready to launch into learning more about innovating and advancing research in liver cancers. Sit back, relax, and get ready to feel engaged. Our first session, Liver Cancers Research Updates, will begin shortly. Thank you. Hello and welcome to this session on liver cancer research updates. I am your facilitator today, Sarah Maines, the program director of the Liver Cancers Department at Global Liver Institute. And today I am joined by our three esteemed guests. Dr. Ahmed Kaseb, Professor and Program Director of Hepatocellular Carcinoma in the Department of GI Medical Oncology at University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Mark McNiven, Consultant for the Division of GI and Hepatology in the Department of Internal Medicine at Mayo Clinic in Rochester, Minnesota. And Dr. Bruno Sangro, Head of the Hepatology Unit and Internal Medicine Specialist at Clínica Universidad de Navarra in Madrid, Spain. Dr. Kaseb and Dr. McNiven are two principal investigators, PIs, at MD Anderson and Mayo Clinic, respectively, who were granted a SPORE, Specialized Programs of Research Excellence, a program funded by the National Cancer Institute. Dr. Sangro is one of 3 PIs for a clinical trial being conducted to explore the efficacy of a drug combination administered to those with resectable HCC. Thank you 3 so much for being here today. To begin, this is a question for all 3 of you that I would love for you to answer. It takes collaboration and a team of researchers and doctors to conduct liver cancer research. Would you describe the roles that you are involved with in your research projects and speak on what type of research you are conducting and what your projects aim to achieve? Dr. Kaseb, do you want to start?
Sure. Of course, needless to say, in this day and age, managing hepatocellular carcinoma is a multidisciplinary task, and we always take pride of that between medical oncology, hepatology, surgical oncology, interventional radiology, and radiation team as well. So at MD Anderson, we do this on daily basis. We work shoulder to shoulder to help our patients in clinic and also in terms of conducting research. So our research program is based on the collaboration efforts between multidisciplinary teams. And my role as a clinician is to introduce our research ideas to the patients, get them consented and give their approval to conduct the research, and collaborate with different team members to analyze data and samples from those patients, including our patients in clinical trials that incorporates our research findings in immunotherapy, targeted therapy, local and systemic therapy combination strategies for different disease settings as well. Early stage disease, resectable cases, also advanced disease stage. So it's a symbol of how multidisciplinary approach in clinical activities and research can benefit our patients in the end.
Dr. Sangro, could you speak to the type of research you're conducting and what's involved in the projects?
Sure. So I have the privilege to lead a team that is dedicated to doing research and treating patients with liver cancer, biliary tract cancer, and pancreatic cancer as well. So, and being a university and academic hospital with two sites in two different cities in Madrid and Pamplona, and one large research facility just across the street, these marks the kind of research that we are able to do, and we have been doing for the last quite so many years. On the one hand, we do participate in the research that has an immediate benefit in terms of patients changing opportunities. And this is usually collaborations with the industry in taking whatever drug or therapy has shown encouraging results in early research activities to the final step where it has to be proven beneficial for individual patients. Then, secondly, we do what we call translational research. We have our own facilities where we interrogate what happens to our patients, the patients we treat. We collect samples of blood, of tumors, and then in our own lab, we try to answer questions like, is this the best possible treatment for this person, or is it not? What can we do to expand the indications of a certain treatment? And then we collaborate with more basic researchers, usually working with animal models or engineers working in their labs as well, trying to promote the knowledge about the diseases that may eventually lead to better therapies to be produced in the coming years. So this is a scope of thing that we work in.
Thank you so much. And Dr. McNiven.
Yes, thanks. Just to back up 5 or 6 years when we got involved with this spore, as you described them, we noticed that despite the fact that liver cancers are on the rise and will become the second leading cause of cancer deaths within the next 5 years or so, we noticed in the NCI portfolio that of the 30 to 40 different spore programs, that there were none focused solely on hepatobiliary cancers. There were some on general GI cancers that might have had a liver component to them, but nothing focused on the liver per se. And there could have been several different spores focused on thyroid cancers, prostate, breast, and so forth. So we thought that there was a real need in the community to pursue this. Mayo has a pretty deep bench in regards to liver biology and treating liver patients. So we assembled a group of 4 different projects focused on 3 of the most prevalent liver cancers that our patients suffer from. One being hepatocellular carcinoma, or the main parenchymal cells of the liver. The second being cancers of the biliary tree, or cholangiocarcinoma, both of these quite lethal. And then a third, we collaborated with an expert from the Rockefeller University in Manhattan, who is perhaps the world expert on a fairly rare pediatric liver cancer called fibrolamellar hepatocellular carcinoma. He's made great inroads in that area, in part because of his talents, in part because of his daughter had her liver resected 10 years ago from that cancer. So he has an emotional incentive to pursue this with great haste. So that's kind of an overview of our SPORE in collaboration with several core facilities that we set up that collect. I think we have one of the largest collection of human patient liver cancer samples in the country, in part from the efforts of my co-PI, Dr. Lewis Roberts, as well as statistical and bioinformatics help and so forth. So that's kind of an overview to our core. But I think Ahmed also has a SPORE, very nice at MD Anderson, and with some different emphasis than we have, but no less important.
And I'm curious, as you spoke to your focus areas, and one of the things I'm most excited about bringing the 3 of you together in that space is, what does collaborative efforts look like in the field of liver cancers research? Is this kind of a first of its kind right now that we're all together talking about this, or do you all utilize each other to look at what should be focused on? Where are areas that we need to achieve and jump into? What does that look like?
Well, if I may jump in, I think there are many things that are unique to liver cancer. One of them is that in terms of research and researchers, it's a relatively small world, and we happen to know each other and in a very special way in many cases, and you would be surprised the kind of collaboration that you can find among the liver cancer research community compared to other cancers. Probably some of the difficulties in doing research in liver cancer is behind this close collaboration. But I would say we do have a very open-minded approach to collaborations in liver cancer. I don't know whether you both would agree with that, Mark and Ahmed.
Absolutely.
Yeah, for sure. And as Bruno said, this is a small community. We all know each other. We meet frequently at conferences and ad boards and NCI and global steering committees. And for example, I give Bruno the full credit for starting the first study ever for immunotherapy more than 10 years ago, nivolumab, and no one knew that this is going to transform HCC as we know it. Not a lot of people know this, but this is something that we know each other that well. So I think it goes to the heart of how this disease has brought all of us together, and it is a must to manage patients in that way. You here have a perfect example of this kind of collaboration: oncologists, pathologists, and scientists, and this is exactly how we can move the needle in this field, and this is how the future looks like. And we do this on a daily basis. Each one of us at our own institutions work together with the rest of the team, literally on a daily basis, to conduct, some studies, look into some very specific study design, how we can collect samples, what testing is going to be applied, and eventually, how we can collaborate with other institutions as well, because this is not a disease that a single institution can manage, neither should be, because we all believe in the fact that this is a global disease.
You both said that perfectly. Dr. McNiven, anything to add there?
Yeah, they're right on. And to emphasize the fact that these cancers are exceptionally complex, and no one individual really has the expertise to approach understanding and treating these cancers by themselves. So as examples, we have projects that combine immunologists with virologists for viral therapy, immunotherapy, cancer cell biology, bioinformatics. So it really is a team approach, both within our own institutions and, as both Bruno and Ahmed have said, extending out into surrounding collaborative groups.
Agreed. I mean, it's almost the multidisciplinary team approach on a global scale, which is quite profound. And I would imagine other disease states, cancer and beyond, that says a lot. You can see, as all three of you spoke to, the liver community, and especially liver cancer community itself, is so small. And to see that collaborative nature, no one person or place can do it alone. So you can feel that just in what the three of you said. Well, and one of the things that I'm curious is looking to lessons learned from other disease states. So according to the CDC, 65% of liver cancers cases in the United States arise from hepatitis B and C, and pre-existing health conditions like obesity and diabetes are also risk factors for cancer. So how do you leverage knowledge in other disease states to guide your research in the liver cancer space? And which disease states or health conditions are most prominent to consider for your research with the patient population?
Yeah, I can get started here. So for this is also, again, another very specific example about the need for multidisciplinary approaches here. And most of our patients have chronic liver disease, hepatitis mainly in many countries around the world, and of course, fatty liver and NASH, non-alcoholic steatohepatitis. So we cannot work alone. We have to work with our hepatologists, also our scientists, to figure out the pathogenesis of each specific entity. And we came to know this in the last decade, that it really affects outcome, whether the patients have viral hepatitis or non-viral hepatitis. Their resistance to certain types of therapies also could be linked to the risk factor. And these things are evolving as we speak from different clinical trials. And we are trying to take this to the next level here by doing the collaboration with our hepatologists and scientists and design a clinical trials for specific risk factor, also link it to the pathogenesis of the underlying disease and the consequences of that disease. For example, hepatitis C can lead to more incidence of fibrosis and portal hypertension. So those patients have specific needs and specific parameters to include them in clinical trials. So these are just very specific examples.
And following to that, because we know, as Ahmed said, that there is a population at risk for the reason that they have these pre-existing conditions. We also work in the biology of the disease that leads to the cancer development. Why? Because beyond treating patients, one of the best things you can do is try to prevent cancer from occurring. And of course, you can prevent spreading of viral hepatitis. But for instance, in the metabolic syndrome, is much more difficult to reduce the global burden of the disease. In fact, it's growing. But so if we do research on the process that leads to cancer, we may find ways of preventing it, which would be very beneficial.
Mm-hmm.
I think the increase in liver cancer, to me, is throughout the population is quite interesting. We have vaccines for hepatitis B, although we still have hundreds of thousands in this country that have hepatitis B. We now have very effective treatments for hepatitis C, and those numbers are going down. The numbers that are increasing, over 40% of us have fatty liver, as Bruno was alluding to. And for example, the leading cause of liver transplantation at the Mayo Clinic now is not hepatitis, but it is fatty liver. And so that clearly plays a role in this increase, but I think there's other factors as well, perhaps environmental factors that, many of us grew up in the 50s, 60s, and 70s before there were environmental restrictions on toxin dumping and cleanup. I know, using the fibrolamellar hepatocellular carcinoma example, they're finding that a lot of these young people that get these cancers have grown up in environmentally toxic hotspots around the country. And so these factors, which are much harder to identify, I think are clearly playing a role.
No, thank you. So much to be done in this space, and already to hear kind of what those areas of focus are that are triggering attention, and learning that from other disease states, but really focusing on that metabolic area with hepatitis. So thank you for sharing that. And one of the things that I want to move the conversation into, Global Liver Institute highly focuses on health equity and disparities within all liver disease types. And unfortunately, gaps in research result in the marginalization of certain communities. We are finding this and seeing this, especially with scarcity of data on liver cancers in the LGBTQIA+ population and community, for example. So if we were to put an ethnic or a racial lens to this, such that Texas, home to MD Anderson, Minnesota, home to Mayo, Madrid, home to Universidad de Navarra, 3 different corners of the globe. What are the challenges of creating diverse populations in your research studies, and how are experts preventing these gaps through liver cancer research? I know through both spores that I sit on a panel of advocates that we talk about the individuals in our communities. How do we make sure they're represented? What does this look like for the 3 of you, and how does that guide how you are conducting research?
Yeah, so I can shed some light on that. And, our institutions are mirror image of each other. Major institutions attract, local and international patients. All of us see patients who come needing a translator, patients who come with, with a different cultural and background. So in general, as you mentioned, it's a healthcare access issue, even within local communities, so healthcare disparity and healthcare access to healthcare and insurance is one issue. Another issue is, the cultural understanding of clinical trials as well. And this is a cultural barrier. It's not only a language barrier, but a cultural barrier, because we realize that certain ethnicities, even within our own local communities, look at research different. There are some historical background about it, and you have to be able to understand it. So creating an office of healthcare disparity at our institutions, can help, because they can really bring forward this understanding to clinicians and scientists, and we're not trained to do this. And I'd be the first one to admit, neither in medical school or even medical training, we were exposed to understanding the cultural and differences and barriers to inclusion in clinical trials. And we all thought of it initially just very simplistic way. It's access to insurance and healthcare, but it is not. Some patients have the best insurance and healthcare access, but their understanding of clinical trials is different. So that's one aspect of it. And another aspect is, and we all face this, those patients who come from international or surrounding countries and they don't have insurance coverage. they also have some difficulties in being included in clinical trials because of the cost. If you have clinical trial coverage through your insurance policy, it's different from somebody who's paying cash, for example. So that's another aspect of it that has to do with the pharmaceutical companies' inclusiveness to include patients from underserved communities.
Yeah, if I may add, I would certainly echo everything that Ahmed has said, and I would like to add that we are the hospitals and our research facility. We can open the door, but we cannot push the patients into it, and so we need to educate the community. This is very important on the relevance of medical research as the only way to move forward. And when it comes to analyzing the impacts of minorities, and mostly ethnic minorities, in access to research and care, when it comes to liver cancer, I always think of Africa. So we are considering the problems in our countries, but imagine the situation in a continent that harbors probably the largest burden of liver cancer in the world. And if you take apart some northern countries like Egypt, or southern countries like South Africa, where really the access to care is probably what we could consider in Western countries. In the rest of the African countries, first, we don't know the specificities of liver cancer there, because we don't have access to samples from most of these patients, and still the advances can very difficultly be taken to these countries to benefit individual patients.
I think Bruno's comments on Africa are right on. We've started, my co-director, Lewis Roberts, from himself from Ghana. And so he has led one of the consortiums of the African Consortium on Liver Cancer. And so we have a major initiative, in part sponsored by Mayo, to collect samples from people from sub-Saharan Africa to increase our sample size. So there's really kind of two ways we've excluded minorities unintentionally over the past years. It's in the study of liver cancer and in the treatment. And I think Bruno and Ahmed have touched on the treatment. But in the study, as for many other types of diseases, whether it's cardiovascular or diabetes, our country has had a tendency to focus on white males. And this is something that has to stop. And so I think the burden is on us to collect samples from populations that represent the diversity of our culture, which is not all white male. So we have, I think all three institutions are pursuing this pretty rigorously to aim towards equity in the study of the cancers. And there's also the treatment. Ahmed touched on insurance accessibility. There's also there's two other factors that I've seen. There's trust in some of the communities. So Dr. Roberts has reached out to the Somali community, which is one of the groups, ethnic groups in Minneapolis, to try to make them more comfortable with talking to us at the Mayo Clinic. Because they can be a bit insular in ways, and maybe we're perhaps somewhat insensitive. Another example would be, Mayo also has other sites in Arizona and Florida. We have surgeons that are trying to start clinics in the four corners of Arizona to interact with indigenous populations and Native American cultures. Again, I think a bit of a trust issue of is the Mayo Clinic for them? Will they be treated with respect and sensitivity? And superimposed upon some of those concerns are the fact that there are some stigmas associated with liver cancer, that perhaps one might be viewed as damaging their liver through IV drug use or alcohol abuse and so forth. So those issues superimposed on some of the racial and ethnic sensitivities have made it somewhat difficult, but we clearly need to work harder towards this.
No, I think that your point, thank you, all three of you, that historical medical trauma, hearing you say in Arizona, what does that look like building clinics and sites in the Four Corners? Starting to shift that perspective on how are patients coming to our medical institution, and coupled with the thought, Dr. McNiven, you just talked about the Somali community. I'm based out of Minneapolis, Minnesota, and Dr. Fankoa, who does a lot in the health equity and diversity space of clinical trials. He's actually speaking at this event today. He shared how he was recently at a Somali health event that a patient came up and said, my insurance denied me from receiving care at a clinic, yet I was asked to be involved with a clinical trial, but my access, the accessibility that I have in terms of the geographic distance, time away from work, caring for my family, all of those factors that go in, all three of you had made that point that sometimes that middle-aged Caucasian male, in the two SPORE studies, I know that there's a higher proportion of middle-aged Caucasian women too. It's not representing necessarily the communities who we need to really focus on, especially sub-Saharan Africa, for example. So yes, hearing the way that we are all trying to instill and build trust, along with bringing that awareness into the importance, Dr. Sangro, I believe you had said that, on making sure people see and understand that importance of research and clinical trials and how that defines this path forward. So important. So thank you for speaking to that. In that line of raising awareness to the importance of research and clinical trials, of course, being located in different areas of the world, it's evident that the priorities and challenges are there, and equally COVID-19 showed us how interconnected we are and how much collaboration can happen even if we're not in person. So what are the strategies that are in place to expand public and professional knowledge of the work that's being done? Is that in the non-liver community space? How do you access knowledge and broadcast that about your research?
Yeah, I think, this era of, COVID-19 has taught us in the fact that we can really be productive through virtual communications, and all of us were used before COVID to just meeting in person, and those virtual meetings were non-existent, and even if they happen with a very, very small scale, one-to-one. But I think we came out from COVID realizing that we can collaborate at a distance. We can conduct full-fledged international conferences and symposia and advisory boards online, and we can also communicate with our patients online. So I think it gave us a very specific new dimension here of remote access to patients, and patients are used to it. Some patients actually, up until now, they still like to do the remote visits rather than coming, especially those stable patients. And even in our research, I don't know about, Mark and Bruno's experience in that, but some patients actually get consented now at our institution virtually. We call them and we do that, and we send them some kits for the samples to be sent. So it really will give us, more liberty and freedom going forward to help patients where they are, and they don't have to travel hundreds and thousands of miles to reach access to clinical trials and research.
Yeah. So and there is like a dual effect of COVID, I would say, in terms of communication. On the one hand, as Ahmed said, we're here, we are virtually meeting today, and that has expanded our reach to receive and to provide information. And to work together. There's no doubt. At the same time, last week at ASCO, I realized such a large meeting. Everybody was happy in meeting each other, and there is some part of the professional interaction that has to occur face to face, and I think these realizing that the virtual communication is important, but the face to face communication is also important. This has been one of the lessons that we learned from COVID. And one thing I would like to add is you spoke, Sarah, about how to expand the knowledge about what we're doing, and I think we're not doing well in that regard, and probably one of the reasons why there are still communities and individual persons that see research with some distance is the fact that they don't know what research is about and what is the impact of research in their lives, in their daily lives. Of course, research news are not as profitable for media as other news, but I think we have not paid enough attention in conveying to the public what we do and how that is important and how that is changing life on a daily basis. And I think we have a lot to do in that regard.
I do think we need to outreach more. I think video, virtual interactions help. I think showing communities that you're taking the time to go and meet with them and explain things goes a long way. And I think, and this gets back to not only the diversity of the patient base or the sample base of the experiments we do, but a diverse workforce. And so are the scientists, nurses, and physicians that are interacting with the public, are they like them? Do they represent individuals that if I'm from North Africa and I go and I say, oh, this person is kind of like me and shares my values and looks at the world the way I do. You mentioned Dr. Fankua from Mayo, who is of African descent. And so we need a more diverse workforce that will be able to make these different cultures, some of which liver cancers are predominant, feel more comfortable towards our interactions.
Excellent points. And speaking to some of these challenges outside the space of kind of the diverse population that we're serving and making sure that disparities in health equity is approached, how can you speak to some of the challenges that have arisen with liver cancer research outside of that? And what advice would you give to future PIs to overcome those challenges with your research?
Well, one of the challenges, and is one of the uniqueness of liver cancer, is that in certain situations, frequently, I would say, in the setting of liver cirrhosis, you can diagnose liver cancer without the need of a confirming biopsy, which is something that does not happen in other tumor types. And this, from a research perspective, has not been a good thing, because the availability of tissue for conducting research that led us to understand the biology of the tumors has been delayed. And I think in we all generally, particularly at centers like ours, where there is a strong research activity, have changed our perspective, and we now do, but we need more medical centers to join us in the addressing the need for an extensive sample procurement that may help advance the field. And for a PI, I mean, what I would tell any PI is this is a good field to work in, because we only recently have started to change things. So we have everything in front of us. The future will depend on how well we do our work in terms of research. It's a nice field for any PI interested in oncology.
Yeah, I totally agree with that. And, I partially blame, lack of a multidisciplinary approaches at the time when, this issue came about, almost 20 years ago, when the societies implemented this strategy to diagnose HCC without a biopsy, which came out of mainly safety issue, right? They didn't want patients with very advanced cirrhosis and ascites, fluid in their abdomen, and a coagulopathy, meaning, the blood is too thin, to undergo a risky procedure that could land them in the ICU for him, bleeding under the capsule and all of that. But then, because there was not a lot of communication or multidisciplinary approach, it was not discussed in a way we are discussing it now. So the field lost a lot. And Mark can attest to that, that there is not a lot of tissue banks for HCC, but this has been changing, and believe it or not, even here at my institution, when I joined 16 years ago, when I started to order biopsies, I used to get a call from the IR team, interventional radiology. Why are you ordering it? It's consistent with HCC and imaging. So go to the heart of how this, issue was kind of universal up until now. In small community hospitals, they still are reluctant to do it. But I think the field is changing, and people are seeing the effect of getting the biopsies with Mark and other scientists around the world, doing immune profiling, molecular profiling, all of that. So I think you're going to see a lot of advancement in the next 10 years in HCC, and there is huge acceleration of these efforts in HCC. For example, in immunotherapy, just in the last couple of years, we had so many advances in early and late stage disease. So that's a big advantage to multidisciplinary management, that any little change can be translated into huge accelerated effects in advancing research.
Later this morning, I give a talk to graduate students on how this is an exciting time to be a biomedical scientist, and it truly is. The first human genome was sequenced in 2003, and now our three institutions have tens of thousands of our patients with their whole genome sequenced. And with that information, coupled with our ability to manipulate genomes through CRISPR and Cas technologies, amazing imaging technologies, this is, I encourage people, and as Bruno says, working on the liver is an exciting organ. It's so important. We can't live without it. It does so many different things. When we're talking about obstacles, which I think is one word that you brought up, Sarah, I do raise the obstacle of support, financial support. The NCI has its budget cut. As Ahmed knows, it seems like every year our SPOR gets cut 10%. And so that adds up over 3 or 4 years to 30 or 40%. And so, these grants are not a lot to begin with. And the pay line for investigators who have a lab and want to work on liver cancer and be funded by the NCI, independent of a spore, is about 9 to 11 percentile. So you need to write a grant with an A or an A plus, and you need to do that every 4 to 5 years over the course of a career. So it's hard to be an A plus all of the time. And so I think this underlies the importance of the Global Liver Institute and others like it to help let their Congress people know that liver cancer is important to them and support of that. I'm a little confused of why there's cuts in the NCI, particular with President Biden's Cancer Moonshot initiative. And so I don't quite understand the politics behind that. But funding is clearly a challenge. I don't know how it is in Spain, Bruno.
It's absolutely the same. I can just echo what you said about although the research programs are different, but at the end the difficulties in finding funding for research are quite similar, even at the European Union level. And one thing that I would like to bring is that I think has an impact on funding is the stigma around liver cancer. And this, I mean, the stigma, which is a huge problem from a patient perspective and care perspective, because stigma is behind delayed diagnosis, more difficult access to care, etc. But also impacts on funding. So, and you would. I've never done the numbers, but I'm sure if you plot the different tumor types and the number of funding activities, non-governmental funding activities, you would see liver is in the bottom. And the stigma around liver diseases in general, many people believing that this is just non-healthy life that is leading to liver diseases.
Yeah, there's somebody to blame for it. And I've actually compared the funding, the non-NIH funding for breast, prostate, liver, and lung cancer, and liver. I mean, to the congratulations of the breast cancer community, they have integrated breast cancer into the vernacular of the American culture, right? You see NFL football players with pink shoes or a pink arm sleeve, and there's all kinds of events and things. So it's in the forefront of when people think about cancer, and we have a lot of work to do in that regard for liver cancer.
We do, and thank you. First of all, from the space that GLI holds and how Donna Cryer, our founder and CEO, really looked at the importance of driving policy, driving patient advocacy and education, how essentially vital that is on a global scale. And to your point specific to the Cancer Moonshot, that is an area that's a concern to us, that motivates us to push harder to make sure we're trying to get memos out there to create awareness on liver health, and liver cancer needs to be spoken about. There are large gaps there on global government scales on why that's missing. And to your point on the statistics in the coming years and the continuing rise of occurrence and the morbidity levels, liver has to be talked about on a very grand scale. So truly so much work to be made in these spaces that there are challenges and obstacles. Equally, there's been a lot of areas of success and celebration. Have there been in the last few years any really surprising areas that you've seen that we can celebrate and speak to those achievements? And how do you see those parts improving the liver cancer landscape down the road?
I would say Bruno's immunotherapeutic approaches to HCC. I put that at the top of the list, along with his colleagues close and far away. So that's very encouraging.
I absolutely
I echo that. I echo what Mark said, and along the same line, we use the same therapy that Bruno used for advanced metastatic HCC in early stage, resectable HCC, and we showed, for the first time that some patients, 30% had shown some massive pathologic response, complete response, 100% necrosis. It's a small pilot study that we conducted through SPORE, but it also opened, this field to get into this early stage disease, because just as much as we suffer in the advanced disease stage of poor outcome and poor survival, patients who go for surgery, majority of them recur. So that's an area of research that, we have been advancing as, global community for HCC. Every country now has got some studies in this space to introduce immunotherapy before surgery.
Yeah, absolutely agree with that. I think I'm pretty sure that neoadjuvant would be significantly better than adjuvant, following your ideas, Ahmed. And if I may add to that, I think what we have learned over the last decade is that building upon the strength of the immune system give us the opportunity, because this is just the beginning. I mean, immune checkpoint inhibitors, the drugs we now use, it's just one form of enabling the immune system to fight against cancer. So we have a huge opportunity to by doing good research and exchanging our knowledge, do collaborative efforts that may find better ways to improve the efficiency of the immune system. And I'm sure the next decade would see a bloom in immune therapies other than immune checkpoint inhibitors.
Agreed.
Absolutely. This conversation has been excellent. I'm just so thankful for the three of you being here, but the way that you contribute to the liver cancer research space, I am profoundly appreciative. So thank you for that. And as we wrap up this session, I want to turn to the three of you with any closing thoughts or comments that you want to make regarding liver cancer research in this space.
I would let everybody know that liver cancer research is for patients. We doctors do it, we researchers do it, but it's for patients. It's the only thing we have in mind when we design our research.
We'd like to thank you, Sarah, for having us and for helping us get the word out and conveying some of these challenging concepts and some of the things that challenge us and everything that the GLI does. So please let us know if we can help more in the future in some way.
Thank you.
Yes, I totally agree. And I would say that the Global Liver Institute is uniquely positioned to also help advocate, those issues. As Mark said, the house of power everywhere through patient advocacy, and follow the footsteps of the breast, community and pancreatic community. We have faith in you, and we're here to help you out to reach that goal, to help our patients in the end.
Well, thank you. And Dr. McNiven, Dr. Sangro, Dr. Kaseb, your passion and knowledge truly jumps out from the screen. And Dr. Sangro, like you said, it's a wonderful privilege to be able to be in this space on a virtual level and reach out to those of you who are watching us today. Thank you. I'm grateful for your support at Global Liver Institute and on a global scale, and appreciate all that you are doing in this space. Thank you.
Thank you.
Thank you, Sarah.
Thank you. Thank you.
And up next, I hope all of you will continue to stay on and join us for an informative session about liver cancer screening options and innovation. This conversation will be led by Dr. Nihar Parikh, the Assistant Professor and Director of the Liver Tumor Program in the Division of GI and Hepatology at the University of Michigan, and Dr. Amit Singhal, Professor of Medicine in the Division of Digestive and Liver Diseases, and Chief of Hepatology and Medical Director of the Liver Tumor Program at University of Texas Southwestern Medical Center. Dr. Parikh and Dr. Singhal, thank you so much for being here and joining us today.
Thanks, Sarah. I'm really excited to be here. Really happy that Global Liver Institute organized this presentation to talk about all the exciting advances in HCC across the board, from epidemiology to surveillance to treatment. I have the pleasure of talking today with one of my friends and colleagues, Nihar from the University of Michigan. And today we're going to be excited. We're going to be talking about several of the exciting advances in HCC surveillance.
All right. Well, thank you, Amit, for that introduction. Thank you, Sarah, again, for introducing us. So, we're going to start off talking about a general framework for HCC screening and surveillance. We'll use those terms somewhat interchangeably. But I think anytime we talk about this, we have to understand what the population is that we want to do surveillance in, and then think about how we balance the benefits of screening or surveillance and any harms that are associated with it. And so that's the general framework we'll be working with today. So I think when we look at this slide, you can see here the population groups that are recommended to undergo surveillance are patients with cirrhosis of any etiology. It doesn't really matter, but the incidence is high enough, greater than 0.8% per year, to justify doing surveillance. There are certain populations without cirrhosis that we would, consider surveillance in, and those are mostly chronically infected, or patients chronically infected with hepatitis B. So, any men with from any endemic country, like most commonly in the U.S., are from Asia that are greater than 40 years old. Any women from these same areas that are greater than 50 years old. Any persons from Africa at an earlier age, and that's a little bit unclear exactly where that starts, but some people advocate over 25. If anybody has a family history of HCC, and there's a risk stratification score called the PAGE-B score that has been shown to be predictive of who's developing HCC. So if you have a score greater than or equal to 10, HCC surveillance is recommended. Notably on this slide, we look at populations that we don't necessarily recommend surveillance. Those are patients with advanced fibrosis, like stage 3 fibrosis or non-cirrhotic NAFLD. Even though we're seeing more patients with NAFLD or non-alcoholic fatty liver disease with HCC without cirrhosis, the population is just so big, there's no recommendation at this point for screening in that population in general. The seesaw here really looks at these benefits and harms, and really the benefits of screening, of any screening program, is early detection, receipt of curative therapy, and improvement in survival. But we always have to balance that against the harms, which is why we don't do screening in really low incidence populations. And these can be physical complications, psychological distress, and then the financial burden that comes with any screening, co-pays, travel, these sorts of things. And so we really have to figure out this balance, and there's several things that alter this balance, including the risk of HCC, the degree of their competing risks, including liver dysfunction and other medical comorbidities, their age, which could be a competing risk, or could play into role in their comorbidity burden, and their preferences. What are their goals, what are their preferences, and what are the burdens of screening? So that's the general framework we work off of.
Yeah, Nihar, I think that this is an important concept, that HCC surveillance, even though it has many benefits, we have to really think of this overall value, and I think this is helpful both from a population perspective, as well as when we see an individual patient in clinic. And so some of these things, particularly when you get into the gray zones, do require fairly nuanced conversations of when should you start, when should you stop, and these things can be somewhat difficult conversations, but I think are important as we think through the true overall value of these surveillance programs.
I think that's right on, and it's true for any screening, really. And we see this with colorectal, breast, but I think these are areas that have not been quite as well worked out in liver. So I think we'll see how that goes. So.
Yeah, and so when we think of the benefits, there have been the best data for the benefits of HCC surveillance continues to come from a large trial among patients with chronic hepatitis B. So when we think through patients with chronic hepatitis B, there was a large randomized control trial that was conducted in China many years ago, which actually showed significant improvements in early detection, and remains the only randomized data that shows reduced HCC-related mortality. Now, that's an important trial, and I don't think will ever be replicated in that sense. But there have been several cohort studies that look at the benefits of HCC surveillance in patients with cirrhosis, and from a Western world perspective, this is the main at-risk cohort that we see. Right, we see patients with cirrhosis more than patients with non-cirrhotic hepatitis B. And so this is a meta-analysis, that we published a year ago that, really enumerates the benefits of HCC surveillance. Shows the association between surveillance with early stage HCC detection, the association with curative therapy receipt, and the association with mortality. And, as you can see from the boxes on the left-hand side, we can see significant associations with each of these clinical outcomes. And most notably, we see a consistent association between HCC surveillance and improved survival. Now, we do know, of course, that these cohort studies can have biases. There can be lead time bias, where you find a tumor earlier and follow those patients longer. And there can be length time bias, where you're more likely to detect indolent tumors. And even in the subset of studies that statistically adjusted for these different biases, we continue to see an association between HCC surveillance and improved outcomes, including survival. And so even though the data are imperfect, the data are consistent, and the data do suggest that we do see benefits of HCC surveillance.
Yeah, and I think this really speaks also to the continuum of care that we see, that we should always consider when we think about screening programs, because I think that looking at all of these outcomes is important, because we can detect tumors early, but if you don't offer curative therapies, you may not see a survival benefit. But to see the signal be consistent across the three outcomes is somewhat reassuring, even though this is cohort data and not necessarily randomized studies that are supporting HCC surveillance use.
Yeah. So Nihar, do you want to walk us through, that was the benefits, like what is, this idea of, screening harms, and how should we conceptualize this in our mind?
Yeah, so I think this has been well established again for other cancers, and there's a certain taxonomy that's used for cancer screening harms. And I touched on this earlier a little bit, but there are broad categories, including physical harms. So these are related to screening or follow-up tests. So for example, if a patient needs a CAT scan because of an abnormal ultrasound, there is a radiation exposure that's associated with that, and you could consider that to be a physical harm associated with this. And then, this extends beyond, other complications, including discomfort, whether they would need a biopsy. There are several of these physical harms that patients can endure, and that we see in HCC surveillance in particular. Certainly, I mentioned financial harms, the direct costs of screening and follow-up, but there's indirect costs also due to missed work, transportation. A lot of our patients complain about parking, for example, and if a patient needs a separate appointment for their screening, that can be a financial harm that they have to endure. And certainly there's psychological harms. So anytime there's a result that is pending, certainly many of my patients get anxious about that, especially if they've had an abnormal result in the past. If they have an abnormal result, what does that mean? And, you're waiting for the workup for that. In the case of an ultrasound, you would get an MRI or a CAT scan. And, there is anxiety in between while we're working that up. And if they are found to have cancer, there can be depression, anxiety, et cetera, associated with that. So these are certainly the harms associated with screening that have been well described and clearly apply to HCC in particular.
So, I think that's great, Nihar. And, I think when we take a look at the data, I mean, you've said this a couple of different times, is that, I think the data on harms are much more mature for many other cancers. And I think it's, a literature that's just coming into its own when we think through HCC. And so, we published one of the first studies on this topic in terms of the physical harms of HCC surveillance now about 5 years ago. And this was a simple retrospective study at that time. 680 patients with cirrhosis who were followed for 3 years. And in this retrospective study, we really quantified both the benefits and the harms. We defined the benefits as early detection. And so, in this cohort, there were 34 patients who were found to have HCC at an early stage and, presumably then, facilitated curative therapies and improved the survival of those 34 patients. Now, conversely, we saw physical harms in 187 patients. And so now, you talked about this, that of course there's different severities of physical harms. And in this study, we define physical harms as any CT or MRI or any diagnostic evaluation that was done for a false positive or indeterminate result. And we acknowledge, of course, that a single CT scan or a single MRI is not notable physical harms, but it does fit that taxonomy that you talked about that's been established across cancer types. But we did find moderate to severe harm in about 59 patients. And so that's repeated imaging or invasive testing like a biopsy. And so this was in 10% of the cohort. And so, I think, this doesn't necessarily say that HCC surveillance is bad or it's good. I think it's more so, once again, about getting the concept of quantifying this overall value when you're talking to your patients and talking about what may be, beneficial and what may be harmful for each individual patient as well as populations undergoing HCC surveillance. And now, over time, we've seen, additional studies come out. But in contrast to, the many studies that we see enumerating benefits, at the time of this prior meta-analysis, there were only 4 studies that looked at potential harms. And, when you take a look at this, all 4 studies quantified physical harms. And this was found in about 9% to 28%, depending on how long those patients were followed. And the good news is that most of the harms, much like the prior study that I reviewed, were mild in severity, single CT scan, single MRI. So the harms did not appear to be, notable or worrisome in these studies that do exist. Once again, at the time of that prior meta-analysis, now about a year ago, there were no data on financial or psychological harms, although we are starting to see some of these data now come out in the literature. And so, the first paper on psychological harms was just published earlier this year, where, to your point of patients, when they were diagnosed with cancer, there was anxiety and depression noted in those patients with true positive results that was increased over time. Those patients with true negative results, so no evidence of no evidence of any positive screening results, actually had decreases in their anxiety. So there was reassurance by negative screening results. But those patients with false positive or indeterminate results were found to have mild, intermittent spikes in anxiety. And so, they would have a false positive, they would have a spike in their anxiety. Over time, it would abate, but then it would, potentially go back up over time if they had another positive result. And, one of the things that we'll talk about as we get later in this discussion is this diagnostic evaluation. And sometimes we think of this as being like, oh, you get your test result and you get your diagnostic evaluation and you're done. But unfortunately, some of these patients end up in these indeterminate categories, these LIRADS-3, these LIRADS-4 lesions, and they have very prolonged diagnostic evaluations and time to diagnostic resolution. And in those patients, we actually found that the psychological distress was actually prolonged. And so I think this is just, once again, something that we need to consider as we go through and we once again look at this overall value. So Nihar, now that we've talked about the overall framework, right? We've talked about the benefits, we've talked about the harms, and overall, I think the data at this point suggests that HCC surveillance is overall, has good value. Do you want to talk us through how we should do HCC surveillance? Like, what are the tests we use in these patients with, cirrhosis?
Yeah, I think that's a good kind of transition here to kind of what do we do here. And so the current recommendations include abdominal ultrasound every 6 months, and the addition of a serum alpha-fetoprotein along with that abdominal ultrasound. And that's been borne out in the latest guidelines that were published for HCC surveillance, or HCC diagnosis and management that just recently came out to show this. Now, of course, abdominal ultrasound is an imaging-based test. And with any imaging-based test, there's going to be variance. And, there's not only variance in the quality of the imaging, the, windows that you get, there's variance in the patients that you have, and the ability to visualize the liver may depend on some of those factors. And we'll talk through some of those as well. This is a really nice slide from one of the previous meta-analysis that was done to support the use of ultrasound plus alpha-fetoprotein for early detection to show the heterogeneity in ultrasound performance. And you can see here the sensitivity on the far right side in these studies ranged from 21% to 89%. And that really speaks to that, variance that I talked about earlier. In this study, ultrasound alone had an early stage sensitivity of about 47%. That increased to about 63% when you add that alpha-fetoprotein in, which is part of where the recommendations came from. So, Ahmed, you want to talk about what leads to that heterogeneity a little bit more?
Yeah, I think, Nihar, that's, I think we're starting to realize that ultrasound is a good test, but an imperfect test. And, I think one of the reasons why this happens is because ultrasound visualization can be impaired in many patients. And so, we find that, ultrasound visualization can be graded by the LIRADS visualization score. And this, I think increasingly we're finding the importance of reporting this, on every ultrasound exam. And so that visualization can be graded using this scoring system ranging from A to C, and it's like grade school. A is good, C is poor. We find that about 80% of ultrasounds actually have, good visualization score A. Unfortunately, that means about 20% of patients actually have poor visualization or suboptimal visualization, about 12 to 13% in this moderate limitations category of visualization score B, and about 5% having a visualization score of C, severely limited. And I think notably, these poor visualization or suboptimal visualizations are higher or more likely when you have non-viral liver disease, when you have obesity, and when you have impaired liver function, Child-Pugh B or C. And now this is concerning because of the epidemiology of liver disease and HCC across the globe, right? I mean, we're going from a viral-related issue to more and more patients having alcohol-related liver disease or NASH-related liver disease. And we're having unfortunately, a population with more and more obesity and morbid obesity. And so this suggests that ultrasound is not a fine wine, right? It's not going to get better over time. It's actually going to do worse over time. This is particularly important because these poor visualization scores are associated with decreased sensitivity and specificity. So they directly translate into worse test performance. And so, this really highlights that because of poor visualization, we need to think through what we can do better and how we can improve sensitivity and specificity for early stage HCC detection. And so one of the things that we can do today is add an AFP, this biomarker that's readily available and that can improve test performance. And so, Nihar, why don't you walk us through the data? I mean, you already mentioned this briefly in the meta-analysis. You and I have done this modeling study where we also looked at the cost effectiveness. Do you want to talk through why we should use AFP in addition to ultrasound now?
Yeah, I mean, so I mentioned that the sensitivity variance with ultrasound with it versus without AFP for early detection. certainly the AFP increases sensitivity without, dramatically affecting specificity, which is always a concern when you add on tests, that you'd have more false positives. But, in this meta-analysis, seemed like the benefits of increased sensitivity were outweighed. And then we did a modeling study, and this is the example of a willingness to pay, our cost acceptability curve, and the willingness to pay is on the x-axis here. And what we really show is that across all willingness to pays, the ultrasound with AFP is a preferred strategy in the vast majority of cases. And so these modeling studies are useful when you're comparing strategies when you don't have kind of head-to-head data. And so here, we really show that the cost effectiveness of ultrasound and AFP outweighs ultrasound alone and no surveillance. So I think this kind of lends to that narrative where ultrasound and AFP is the preferred strategy at this point, despite all the limitations we've talked about thus far.
And I think that's important. I think, when you take a look at the guidance and the guidelines from, ASLD, there's really been a back and forth, right? I mean, it's like almost like it gives you a little bit of whiplash, like taking a look at ultrasound alone, ultrasound with AFP. And so, I think now there have been increasing data that have looked at this clinical question. And to your point here, not only the pooled results from the studies that do exist, but, modeling studies to really take a look at this on a broader population. And I think the data now really show that ultrasound with AFP is the better strategy at this time while we wait for newer strategies to get validated. And this is reflected in the most recent ASLD guidance document that suggests or recommends ultrasound with AFP, not with or without.
Great.
And I think that, the other thing that, goes along with this is, this recommendation for ultrasound with AFP, but also this recognition from the ASLD that, there is still this impaired visualization on ultrasound. And so, if you have like quote unquote one flat tire, if the ultrasound is giving you poor visualization, that's combination strategy is probably still not sufficient. And so we need to think through what else we can do in that subset of patients. And, you and I will talk about the fact that we need better validation of these emerging modalities. But we are starting to recognize that these patients currently are being impacted. And while we're waiting for validation, there may be patients in whom these promising strategies should be considered today. And so, the ASLD recommends now that those patients with a visualization score of C, i.e. severe limitations, we understand that the ultrasound sensitivity is very low. And in these patients, one can consider a screening contrast-enhanced multiphasic MRI or a CT scan, given the fact that you really don't get very good visualization on the ultrasound. However, I think this is the small subset of patients in whom this strategy should be used. And, for many reasons that we'll discuss, we don't think that CT MRI should be a broad-based strategy until, once again, we have this better validated and evaluated on a population basis.
So let me ask you, kind of on your clinical practice, how are you handling visualization C? I think this is an area that there's not a lot of great data.
Yeah.
And I think it bears to maybe a little bit of a discussion because I think this is where the people are sometimes lost on what to do.
Yeah. So Nihar, I think what we do is first we take a look at where that patient had their ultrasound. So we do know that if somebody gets their ultrasound in the emergency room or in the hospital, there's many reasons why the visualization score may be impaired, right? And that could be related to acute elevations or acute exacerbations of ascites, or the patient not being able to hold their breath because they were critically ill. However, if that ultrasound was done as an outpatient, where you don't expect sort of something reversible as the cause of that poor visualization, once again, these are patients where we will do a screening MRI. And we will do this in short manner, not sort of 6 months from then, but we will do it at that time because we essentially take into account the fact that they didn't really have a good screening exam for that window. But if they had this done, as I said, as an inpatient or emergency room, and we think that the visualization may improve then we would consider getting a repeat ultrasound as an outpatient after that patient improves. How do you do this in your center?
Yeah, I think it varies at our center depending on our providers, and it depends on somewhat the kind of patient situation, as you mentioned, of like how they got their screening. But in general, the way that we approach this is if somebody has a visualization score of C, or for whatever reason, an inadequate exam because they had it as an inpatient or in the emergency room. Sometimes the providers will get a CT or MRI on something like an annual or every 18-month basis, rather than doing it at every 6-month windows. And in the interim, they'll get that ultrasound regardless at the 6-month interval that they're not having the imaging, along with that alpha fetoprotein. So I think it's an area that, there's a lot of practice variation, and we see that at our center, certainly.
Yeah, definitely an area where we need more data about what's the best strategy.
Yeah. All right. So, speaking about MRI, I think, it's important to talk about this as a strategy because of the performance. And I think the performance has been shown in this nice study from Korea that looked at, it's called the PRIA study. It was a prospective study. It had 470 patients with child A/B cirrhosis, mostly hepatitis B infected. They had a lot of surveillance over a 1.5 year period, and they had a semi-annual ultrasound and an MRI done in all patients. And out of the 407, there's a fairly high rate of HCC. There's 43 patients were diagnosed with HCC. And I think the important thing is that, on paper, this looks like that MRI is much better because the sensitivity was very high. But remember, these are all very early stage cancers. The question is whether, the ultrasound would have eventually picked these up at an early stage instead of a very early stage. But, it does show how sensitive MRI can be. And so we get sensitivities of, over 80%, 86% versus ultrasound where it's in the mid-20s. Again, these are very small lesions, early stage cancers. And, what we don't know is whether the outcomes would be improved if you get a very early stage HCC diagnosis versus an early stage HCC diagnosis. But this speaks to the promise of an MRI-based strategy. Now, MRI is impractical for a variety of reasons, especially in the U.S. As a surveillance strategy. One is certainly cost. MRIs are much more expensive than ultrasound. The other is access. It's very difficult at some centers to get a routine MRI, even a diagnostic MRI. If you add in a large screening population, that may overload the system in terms of the ability to get MRIs. And certainly the patient factors play a role. The patients have to sit in a tube for 45 minutes and, go through all the sequences that are required with an MRI. Sometimes you have claustrophobia, you have other contraindications like, metal in the body, which can make it difficult to obtain. So an MRI-based strategy looks very good on paper here, but I think there's several caveats to this study. And you think about this in clinical practice, it may not be a totally practical strategy.
I think that's exactly right, Nihar. I think that, once again, it's a great tool with high test performance, but I think we have to think through all of these factors in terms of implementation if we really wanted to move this forward. So Nihar, one of the things that's been at least advocated or is being evaluated is this concept of an abbreviated MRI. So you're able to shrink that exam down from like 45 minutes down to 15 minutes, and maybe address some of these concerns that you raised. Can you just briefly chat about like what is an abbreviated MRI, and do you think that this really addresses all those concerns that you raised?
So, an abbreviated MRI is limited sequences. Now, exactly which sequences you use and whether you use contrast or not has not been completely well established. There's lots of different protocols out there, but the essential idea is that instead of all the sequences that you would get on a regular liver MRI, it would cut those down in some way to make it a shorter exam. And so, abbreviated MRIs instead of a 45-minute exam can be a 15-minute exam. So quicker, which is, very patient-centric. And, in terms of performance, it has very similar performance. If you look at the different studies, and there's a nice meta-analysis published in Journal of Hepatology last year, which looked at all the published studies of abbreviated MRI performance. And we see something very similar to diagnostic MRIs that you see here in the BRIA study in terms of the sensitivities and specificities. Now, the issues remain that, one is the cost. At this point, there's not a specific code or a billing code for abbreviated MRI. So the cost is the same as a regular MRI. And so in this case, you're not really saving any of that, the money that you, or the money to make this a cost-effective strategy. And the second, I think the capacity issues remain. I think if you start loading up your MRI scanners, even if you were able to get 3 people or 2 people in for the, for a usual liver MRI spot, I think we'd still run into these capacity issues of getting patients into for their exam and getting this done. I think the other nice thing about abbreviated MRI that is, ongoing that we'll wait is there's a large study that's going to be evaluating this in the VA that will be looking at abbreviated MRI versus abdominal ultrasound for surveillance. So we'll get more data in this space, but I think until some of these other logistical issues are concerned, we're going to have a hard time getting widespread uptake of this technology.
Yeah, I completely agree. And I think that, these MRI-based technologies, whether, full MRI or abbreviated MRI, may potentially work in large health systems, academic centers, VA health systems, et cetera. But, particularly when you start talking about this as a national or a global problem, MRI capacity is not evenly distributed. So, here in the United States, you take a look at some of the rural areas of the US and you have, much less MRI access. And then when you take a look at this is a global issue. And there are parts of Africa, for example, where they have a hard time getting an ultrasound, let alone an abbreviated MRI. Other parts of Asia, same kind of issues in terms of MRI access. And then you take a look at healthcare systems where you have, government coverage, Canada, parts of Europe. And I think that this is something that we really need to think through from a larger population perspective. Once again, when you talk about good test performance versus, implementation, even with these abbreviated protocols.
Yeah, I think that the global reach of liver cancer is something we can't ignore for sure.
Yeah. And that's why I think, both you and I are much more excited about the biomarker aspect of this. We've seen, as much as we've seen increasing data about new imaging technologies, we've seen a lot of data come out about emerging biomarkers. And, I think that there's really, when we think of this, there's the, quote unquote historic protein-based biomarkers like AFP, AFPL3, DCP, which have been studied across several different studies. And then there's also the emerging, exciting liquid biopsy techniques like methylated DNA panels, as well as fragmentomics, which we saw recently, an exciting study about that. And so, I think that we're seeing many more biomarkers come out and have promising data. I think there is a recognition that HCC is a heterogeneous disease, so a single biomarker is probably not going to be the answer. You can see that with AFP, for example, that AFP is good, but it's not great. And I think that we're starting to recognize that you probably have to put several of these biomarkers together in panels, really, to achieve sufficient sensitivity and specificity. Now, when we take a look at these panels, probably one of the best validated so far is this panel called GALID, right? So AFP, AFPL3, DCP, and combined with gender and age. And when we look at GALID, GALID has been evaluated in a multinational case control study with the data showed in the table on the left. And you can see that GALID in this study had sensitivities for early stage detection ranging from 60% to 80%, which is quite promising for a biomarker alone, right? And this was recently evaluated in the phase 3 study, the HEAD study done here in the United States. And this showed a sensitivity and specificity of 65% and 82%. Once again, very promising test performance. And, this biomarker panel has now passed, quote unquote, phase 2 and phase 3 evaluation and looks like it will be moving into prospective phase 4 evaluation, later this year. And so this is exciting because if this passes that step, we may actually see this come to market and actually compete with ultrasound-based surveillance as the preferred strategy. Now, as I said, we not only have these panels, we also have liquid biopsy techniques. There's been an exciting case control study for methylated DNA panels, also showing very promising sensitivity and specificity. That's being evaluated in a cross-sectional study at this time. And then we also saw recently some exciting data for fragmentomics, right? These basically fragments that can come off of HCC and have different sizes compared to some of the background liver disease. And I think that we're going to see more and more validation data for all of these promising techniques. And so this may signal a change in how we do HCC surveillance, moving away from imaging totally and potentially moving to a biomarker-based strategy alone.
Yeah,
what do you think, Nihar? You think this has any, viability?
Yeah, I mean, I think when we talk about the barriers and the harms associated with liver cancer screening, I think a biomarker-based approach, could overcome many of those depending on how it's implemented. And I think you talked a little bit about the global piece of this, and even rural populations in the U.S. that may not have good access to healthcare, but getting access to a lab and a blood test may overcome some of those issues that we've seen in terms of some of the disparities in HCC. And this may be a way to in part address that.
Yeah.
I think kind of transitioning a little bit into this kind of patient piece about how people perceive screening tests. I think this is an important part of any surveillance program, because I think that we talk about surveillance. Surveillance is only as good as the test and if people get it. And we've seen really poor surveillance. We haven't gone over the data, but poor surveillance with ultrasound-based screening, which limits the effectiveness of that as a surveillance strategy. We conducted this study. It's a study that was conducted a couple years ago and published. It was 179 patients at 3 health systems that were undergoing HCC surveillance, and we looked at something called we did something called a conjoint study. And what a conjoint study does is it looks at how people value various aspects of anything, like a product or a test. And in this case, we looked at aspects of HCC screening. So what do people really value? And the most important factors were the benefits of screening, which were early detection or the sensitivity, and that was the most important aspect to patients. The logistics was the second, and then the financial harms were the third. But you can see that the sensitivity really outweighed most of the other aspects of screening. Now, this is being repeated in a larger study. When we map these preferences to the actual tests, patients really preferred an abbreviated MRI because it was the most sensitive, and an MRI in general, or blood-based biomarkers. And these were fairly close, but clearly the sensitivity won out here in terms of what they preferred. But really the minority preferred ultrasound and ultrasound AFP, which is the current standard of care, which is very interesting. I think when you think about how we deliver HCC surveillance, we're doing tests that maybe would be less preferential to patients. So I think this is an important study to show that. So, so how do we get to a biomarker? I think you mentioned about going to a phase 4 study. What does that mean, and how does that play into where we are at and where we're going?
Yeah, I think that when we think of this, there's a set algorithm or a set pathway in terms of how new surveillance strategies are validated, and you can see that outlined in the table on the left. This was initially proposed by the Early Detection Research Network, and then recently adapted to really show how this would work for HCC, given some of the nuances in terms of HCC surveillance. And this simply, as you walk through this, goes from from the lab in terms of where you identify a biomarker, you show the initial test performance, and then you walk through a case control and then a retrospective cohort study where you look at test performance. And this is where most biomarkers have ended right now in terms of having this phase 2, case control, or this phase 3 retrospective cohort study data really showing test performance in terms of sensitivity and specificity. But clearly, we've already talked about that test performance is only half of the equation. We really have to see how these things equate to clinical utility, right? How does this actually equate to early detection, curative therapies, and most notably, how does this actually equate to improved survival or reduced cancer-related mortality? And this moves beyond just test performance, because you also have to think through other factors like test adherence. And this really determines the overall effectiveness. And so these are really best evaluated in prospective cohort studies or prospective randomized trials, these phase 4 and these phase 5 studies. And so these are things where you look at stage distribution prospectively, i.e. early detection or late stage detection, and you start to look at the balance of benefits and harms. And so the nice thing is that we are finally starting to move into these phase 4 and phase 5 studies in terms of some of these emerging modalities, both for abbreviated MRI as well as for these emerging biomarker panels. And so I think we're going to start seeing how these actually look in terms of clinical utility, and maybe having something new for guidelines in the near future.
Great. And, I think that the other part of this slide shows really if you increase adherence to testing, and again, we didn't mention the adherence to ultrasound, but that, it can range anywhere from, less than 10% of patients may be getting it, which decreases that effectiveness. So even if you have a really good test and nobody's getting it, you may detect less cases than if you have a really high, like an easy to get test with lower sensitivity, which is the promise of biomarker-based screening. Now, remember, GALAD had a sensitivity of about 65%, which is comparable to ultrasound and AFP. So, what the thought is that even if you have something comparable, if more people are getting it, it may be more effective. So I think that's an important concept. And one reason that, I think an ultrasound or a biomarker-based strategy may be preferential to an imaging-based strategy.
Yeah, and conversely, Nihar, when you take a look at something like MRI-based strategies, you may improve test sensitivity, but you may actually decrease adherence and have lower effectiveness. So I think this is something that we really need to consider with all of these modalities, and that's why sensitivity is not sort of the end-all be-all.
Yeah. So, I think, once a patient undergoes whatever surveillance or screening test that they're undergoing, and in this case, in 2023, we're still talking about ultrasound and AFP-based screening. Question is, what do you do when you find something? And, I think this is a diagnostic algorithm that was published in the most recent guidelines, where, if you have a liver lesion, you need to get a test to follow that up. And, this is the part of that continuum of care that we talk about, where we certainly seen patients in our liver cancer clinics that have had a test, an abnormal test, and, for whatever reason, they did not have a follow-up exam. And they have to have the right follow-up exam. The follow-up exam, again, is a multiphasic abdominal MRI or CT scan is what is typically recommended. And they really have to be protocoled correctly to be diagnostic of what that lesion may be. Again, a lot of these lesions will be false positives. We've seen that. We've described that with ultrasound-based screening. But, you have to have the right imaging to really figure this out. And this is laid out here in the text from the latest guidelines here. And we use something called the LIRADS, and this has been developed and refined over the years. And it is a way we categorize liver lesions on cross-sectional imaging, abdominal CT or MRI. And there are certain characteristics we look for. And Amit, I don't know if you want to run us through these as kind of the way we wrap this up.
Yeah, no, I agree, Nihar. And so I think that, as you mentioned, HCC is really a unique tumor in the fact that we can diagnose this radiographically without the need for a biopsy. But this requires the correct imaging to be done. And that's really this multiphasic imaging that includes an arterial phase, portal venous phase, and delayed phase. For example, a single phase CT scan done in the ED doesn't give you all of those different phases. And so you're not able to actually apply these LIRADS criteria without all of these different phases being represented. And this is a nice table that was taken from the LIRADS core, where you're able to see when you combine these different features, such as arterial phase hyperenhancement, the size of the lesion, and then the presence of these other major features, including an enhancing capsule, non-peripheral washout, that's i.e. being darker in the portal venous or delayed phases than the background liver, or the presence of threshold growth, i.e. growth over time. You're able to classify these patients into these categories ranging from LIRADS 3 to LIRADS 4 to LIRADS 5 in this table. There's also LIRADS 1 and 2, but those are benign and so not included in this table. But LIRADS 3 lesions are intermediate or indeterminate, and they have about a 30% chance of being HCC or turning into HCC over time. LIRADS 4s are suspicious, so about 2/3 of them, will develop HCC over time. And LIRADS 5 is quote unquote definite for HCC, so about 95% positive predictive value. So 95% of these patients will have HCC in that lesion, even without needing a biopsy. And so these patients in clinical practice are typically treated according to the HCC treatment allocation system based on tumor staging and tumor burden. And so, these patients can undergo even treatments such as surgical resection or liver transplantation without requiring a biopsy. And that's really, once again, given this high positive predictive value for having HCC at that time. This has really been a sort of a nice collaboration between the AASLD and LIRADS in terms of these tables and these diagnostic algorithms, being incorporated once again into the most recent guidelines for diagnostic criteria. This being said, there's about 10% of HCCs that don't meet these criteria. And so if you have some of these features, but not enough to meet diagnostic criteria, one should consider a biopsy in those cases because, once again, early diagnosis is still critical in those patients. So with that, Nihar, I know we've been talking for some time now, and we've covered a lot of concepts in terms of the current standard for HCC surveillance, as well as the current standards for diagnosis. Anything you'd like to say in terms of take-home points that we haven't covered, or that you just want to reinforce that our listeners should take home today?
Yeah, I mean, I think that the main points are, right now, and, again, in 2023, our current standard is to perform an ultrasound and AFP every 6 months in patients who are at risk. And that at-risk population, certainly patients with cirrhosis and certain populations with hepatitis B. But I think people should be aware of the evolution of, or some of the limitations of ultrasound and what to do if you have a patient that seems like ultrasound is not being served by. And then, be aware that there are several emerging technologies that are coming out, or surveillance methodologies that will get increasingly more data. And, we may change over the next several years the way we do surveillance to make this more patient-centric and reduce disparities in, HCC that we see at this time.
Yeah, I completely agree, Nihar. So it's an exciting time for HCC surveillance. I mean, ultrasound has been the cornerstone for decades, and now we're starting to finally see these emerging modalities come out. And so I think you're right that we're probably going to see some major changes, over the next several years. I think the other thing, and you've mentioned this a couple times, but we didn't go through it in detail. I think the other thing that I think our listeners should just take home is the fact that, unfortunately, ultrasound and AFP are underused in clinical practice. And so less than 1 in 5 patients who are at risk for HCC currently undergo any surveillance or regular surveillance. And so I think it's the type of thing where, even though there's a lot of excitement about all these new emerging modalities, I think what we have to focus on right now is recognizing our at-risk population, those patients with cirrhosis, and implementing what we currently have in our toolbox. And so doing ultrasound and AFP in these patients, and so we can really get that adherence much higher, on par with the adherence measures we see in other cancers. And that, I think, will really do wonders in terms of making a big dent in terms of HCC-related mortality. So that's what we can do today in 2023, is really focus on increasing adherence. So, with that, Nihar, always balance with you. And so once again, lots of fun today. I think I'd like to end by thanking Sarah for inviting us both here, and thanking Global Liver Institute for really hosting this entire platform of presentations, and all their work in HCC over the years. So thank you.
Yeah, thank you. This is terrific.
Dr. Parikh and Dr. Singhal, wow. The information you just shared about liver cancer's screening options and innovation was so powerful. In the liver community, we passionately talk about the importance of prevention, education, and detection, and I am humbled by the incredible work you are both doing in this space. I'm so appreciative of your time and dedication today. Our final session for the day is titled Reducing Disparities in Clinical Research Trials. I am so excited to welcome Dr. Lionel Fonkoa to the stage. Dr. Fonkoa is the Assistant Professor of Oncology and Senior Associate Consultant within the Department of Medical Oncology at the Mayo Clinic in Rochester, Minnesota. Dr. Fonkoa, welcome.
All right. Well, thank you, Sarah, and thank you, thanks to the Global Liver Institute for really the opportunity to speak today about advancing equity in clinical trials, cancer clinical trials. I'm Lionel Fonkoa. I'm a medical oncologist at the Mayo Clinic in Rochester, Minnesota, and I take care and do research on cancers of the GI tract and liver. So this is the outline of my talk, before I get into how to improve diversity in clinical trials and how to overcome some of the barriers, I think it's important to understand cancer health disparities as a whole, and why these disparities happen, because a lot of the reasons and the solutions are very common, and really can inform what we can do and how we can improve or address the accrual barriers to clinical trials. So I will first talk about cancer health disparities, talk about why diverse representation in research and clinical trials matters. And since this is the Global Liver Institute, I'll take the example of hepatocellular carcinoma, and then talk about cancer clinical trial disparities and some of the barriers to accrual before wrapping up and offer some strategies and resources to address accrual barriers. So this is, in terms of the U.S., looking at cancer disparities in the U.S., you see here on the graph on the left, that's the cancer mortality over about 2 decades. So from 2000 to about 2017. And as you could see, while the overall cancer mortality has declined due to some of the advances in screening and diagnosis and treatment, African Americans continue to disproportionately, shoulder an unequal burden. But beyond looking at just the global trends, I think the devil is always in the details. So you will notice that the specific populations, from various socioeconomic backgrounds and demographic backgrounds, continue to disproportionately shoulder that burden. And on the panel on the right, the table on the right kind of gives you an idea, some of the examples, and you could see that African American men and women have about 111% and 39% higher risk of dying from prostate cancer and breast cancer, respectively, compared to their white counterparts. If you look at American Indian and Alaskan natives, they're twice as likely to develop liver and bile duct cancer as their white counterparts. Patients with localized hepatocellular carcinoma, without health insurance or underinsured, have an overall survival that's less than half as long as those with private health insurance. and for whatever reason, a bisexual woman, have 70% more likely to be diagnosed with cancer than their heterosexual counterpart woman. So as you could see, there are a lot of at-risk populations. When you look closely at that overall data, and here are the biggest at-risk populations listed here, ranging from people from various ancestry, race, ethnicity, socioeconomic status, people who are uninsured, underinsured, where you live, rural locations, LGBTQ members, certain immigrants, refugee or asylum seekers, elderly, and then adolescent and young adults, is also a group that's emerging as an at-risk population across a number of cancers. So it's very important to recognize these at-risk populations and to really make sure that we are including them, or at least having a targeted plan for them. So, why do these disparities exist? Well, they are driven by complex and interrelated factors, what we call social determinants of health, which, context of the United States may have been um, perpetuated or exacerbated by, structural racism and systemic, inequities. And so the figure or the circle on the left there depicts for you how they interconnect and interact both at the societal level, community levels, and even at the individual level, and they collectively impact, every stage of the cancer continuum, leading to really worse health outcomes for racial, ethnic minorities, but also in general underserved populations. So um, and the table on the right there, kind of shows you examples of some of the multifaceted disparities that have resulted from this, ranging from, if, for example, if you look at Black women with breast cancer, experience a delay in surgery beyond 90 days, almost twice as frequently as white women. Black men over the age of 55 or younger with prostate cancer experience treatment delays beyond 6 months. You look at language, non-English speaking Latinas with breast cancer have longer delays, not just in terms of initial uh, evaluation, but even treatment. And I could go on and on. You could see a lot of them listed there. So it may seem like this is a minority pop problem, but if the goal is to achieve high quality care for all, cancer patients, I think the solution lies actually in the collective majority, to ensure that equity, to ensure equity and not just equality. And I think those are terms that are used interchangeably, but they are different. There is a difference. Equality aims to ensure that everyone gets the same things in order to enjoy full healthy lives. Equity involves trying to understand and give people what they need, to enjoy healthy lives. So like equity, equality also aims to promote fairness and justice, but it can only work if everyone starts from the same place and needs the same thing. So I think if you want to make progress in this space, really the majority, the collective majority has to be involved here, and all the stakeholders have to be committed to achieving this goal together. And I'm showing you here on the right kind of who these key stakeholders are, and really it's going to require involvement from at the very high level, federal level, regulatory agencies like the FDA, payers, healthcare providers from all backgrounds. So really, and policymakers as well. So we really need involvement and commitment from all these stakeholders to really make sure we achieve equity in healthcare in general, but most importantly in cancer care. So, moving on to kind of the second point I want to talk about here is kind of why diverse representation in research and clinical trials matters. And so, why do we need the diversity, the diverse representation? And well, if we want to fulfill the promise of precision medicine, which is to provide the right drug to the right patient at the right time, then we need to ensure that our investigations and the data generated from these investigations is actually representative of the diverse population we serve, and thus applicable to all patients. And so that's kind of the essence of what we do. And so I want to use this slide here just to illustrate why data diversity is important. And I think this is was an algorithm that was developed called the pulse algorithm. It's a depixelizer, and what it does is it takes an image that is very pixelated and it depixelates it, and you could see the original pixelated image there on the left. I think we could all probably guess who that is. That's former President Barack Obama. But when you run Barack Obama's image, a pixelated image, through this algorithm, you get a picture of the white gentleman on the right, who's clearly not Obama. But the reason why that happened is because the data that was used to train the model, the algorithm, was derived from white faces, not African American or Asian faces. And so, if you train something to depixelate it, it's gonna think that everybody's white and come up with a white face when it's clearly not. So kind of a parochial example, but not necessarily relevant to cancer, but I think it drives the point that you need to have a data that's reflective of the population that you want to study and intervene on. Um, Another important point is we also need to be intentional about including at-risk populations from the get-go, from the design to the implementation phases of our study. So otherwise, we run the risk of unintentionally creating or exacerbating this disparity. So this right here is actually a study that was published just last year in NGM, and what it highlights is the fact that when we develop things that are going to help people, we really need to make sure that it's going to help everybody. Mammography, screening. If you look at this graph here, it kind of shows you the mortality, breast cancer mortality over the years, and you could see here that prior to 1980, the mortality for Black women and white women was about the same. But then, just around that time, that's when key things were introduced in breast cancer care. Mammography screening and also adjuvant endocrine therapy. So if you are a mammogram. And this highlight, if I start here with just mammography, that highlighted a number of issues. One is access, right? So not all Black women had access to mammography, and then the second thing is the just intrinsic reasons to Black woman breast tissue, which happen to be denser breast tissue than white women. So mammography from that standpoint may not be as effective or maybe less effective in Black women. The third thing is, Black women tend to have a little earlier onset breast cancer. So when we set the age limits for mammography screening, depending on which society or guidelines you look at, they tend to be, Black women tend to develop breast cancer a little earlier than those age limits the organizations set, and so they may not be eligible, when they actually need to get mammography. The other thing here has to do a little bit with biology, because Black women, tend to have triple negative breast cancer. So not the majority of Black women, may not benefit from this adjuvant endocrine therapy because a lot of them are triple negative, and so they are not eligible. So as you can see here, you have two interventions, which are great tools to have, but it's not just access issues, but issues inherent to the development of these good products, and so in this case, screening and treatment that disadvantaged actually the Black woman over the white woman, perhaps unintentionally, but it did. And so we have to kind of think about developing things that are going to have an impact on all populations and equitably, and that's a challenge that we all have to think about as we design studies moving forward. So, shifting gears a little bit here to liver cancer, and as most of you know, the therapeutic landscape for hepatocellular carcinoma has been rapidly evolving over the last few years. For almost a decade, after a decade of sorafenib just being the only therapeutic option that was available, we now have 10 to 11 FDA approved treatment options, with the biggest impact in the modern era, in the realm of, in immunotherapy. And so, why is that important? Because, hepatocellular carcinoma, HCC, tends to I think part of the success of immunotherapy in hepatocellular carcinoma is also due to the fact that it arises in the background of chronic inflammatory conditions, whether it be viral hepatitis or NASH, non-alcoholic steatohepatitis. That leads to molecular changes in the microenvironment, and that leads to cancer. And on the left there, you could see, kind of a classification that's been done on looking at a number of HCC cases, showing that you can have an so-called immune class in about 25% of HCC, that's highly immunogenic, and so more likely to respond or derive greater benefit from immunotherapy. On the right, you could see again kind of similar study showing, distinguishing, different classes, inflamed versus non-inflamed classes, with some of the features that are specific to each class. So again, that context, that etiology actually matters in terms of predicting response, potentially predicting response to immunotherapy. So again, I'm showing you here a diagram showing that, between the viral and non-viral, etiologies. So chronic hepatitis B, hepatitis C, NASH, or alcoholic, steatohepatitis ASH, they all cause chronic inflammation and damage to the liver, through different various mechanisms. HBV tends to kind of increase exhaustion of the effector CD8 T cells, and increase, immunosuppressive cells in the microenvironment. The hepatitis C virus tends to increase CD8 T cell exhaustion, but also immune evasion. Whereas NASH tends to activate dysfunctional T immune cells, so NK cells and other cells. And alcohol causes kind of a bacterial translocation of pathogen-associated molecular patterns, from the gut, leading to increased polarization of M2 macrophages. So again, just to show that really it's not a one size fits all. This is a very heterogeneous patient population with different causes leading to HCC. So looking globally at HCC, at the epidemiology, so when you look at the map there, over 90% of HCC cases actually, like I mentioned earlier, arise in the setting of chronic liver disease, from viral hepatitis, alcohol, NAFLD, NASH, and actually chronic HBV, hepatitis B virus infection actually accounts for about 60% of cases, and a lot of them are predominantly in Asia and Africa, and only about 20% in the West. So, there's a paper that came out in, I think it was 2021, in Nature, by Pfister and colleagues, that made us think a little bit, about the potential impact of the etiology of the HCC on actually response to immunotherapy. And in short, this study that I'm sure a lot of you are familiar with kind of suggested that it was based on preclinical data, but suggested that, non-viral HCC, particularly NASH HCC, might be less responsive to immunotherapy, because, there was kind of a, owing to NASH-related aberrant T cell activation causing tissue damage that led to impaired immune surveillance. And they also showed a meta-analysis of 3 randomized controlled trials, phase 3 trials, that use immunotherapy or PD-L1 inhibitors in HCC, and suggested that meta-analysis suggested that indeed, immunotherapy did not improve survival in patients with non-viral HCC. That's what you see on the right there. So that really started to kind of make us think more closely about the etiology and the impact on immunotherapy. I'm going to highlight a couple of the major trials that led to the two frontline regimen immunotherapy combinations that we have right now, and kind of take a close look at what the subgroup analysis or the post hoc analysis, in terms of etiology suggested. And this is the updated analysis of the I Am Brave 150 study that led to the current standard of care, one of the current standards of care, atezolizumab bevacizumab. And that study compared that regimen to sorafenib. And as we know, it was an overwhelming positive study, and that became a standard of care. But when you look closely at, the panel on the right, which was just published, and this is looking at the etiology, what was the outcome in terms of etiology? And as you could see here, overall, there was no significant difference, across the etiology. So they all derived benefit, and it wasn't one group that had necessarily. Definitely the non-viral, between the viral and non-viral, there wasn't a big difference. Now within the non-viral, that's also a heterogeneous group. But again, we did not see a difference here that was suggested by that early preclinical study. The Himalaya study, which is the other study that led to the other current standard of care frontline regimen of durvalumab and tremelimumab, was a positive study with overall survival benefit. And when you look at, they actually published there, the response, or the not response, but the survival based on etiology. And as you could see here, highlighted in red there in that red box, that when you look at viral etiology, non-viral and both viral and non-viral patients derive benefit. Obviously, the hepatitis B group derived the most benefit. I think the hepatitis C group was not as well represented. You could see that by kind of the wider confidence interval. But when you look at the non-viral etiology, they derived a similar benefit. At least there was benefit in the non-viral etiology group. So again, starting to kind of conflict a little bit with that early preclinical study, or at least the suggestions from that study. They actually, this is a more updated breakdown that was presented at ESMO last year, that kind of shows you the breakdown for HBV, for HCV, for non-viral. And as you could see here, the greatest benefit, again, experienced by hepatitis B virus. But when you look at non-viral etiology, they also derive benefit. More recently, just I think about just this month, actually, over the last week, actually, there was another publication in Journal Hepatology looking at it's a meta-analysis that looked at a number of trials, all of the major trials for immunotherapy in this cancer, and it looked at specifically the question of etiology. And as you could see here, I'm just highlighting in the red box there the data for the two key regimens that are frontline. But again, if you look at the first plot, you see that there was no big difference. I mean, the patients with non-viral liver disease also derive benefit, but the patients with hepatitis B appeared to be deriving the greatest benefit. So I think what all this is saying. I don't think today we can discriminate clinically based on etiology, but at least there are some signals here that maybe they're not all the same. Some may derive greater benefit to immunotherapy than others. So more studies will kind of help teasing that out. So that's kind of important to think about as especially when you look at your patient population in your catchment area. We are here in Minnesota, and people may think this is not the most diverse state, but here in our catchment area, we have a large African immigrant Somali population that develops HCC. A lot of them in the background of viral hepatitis B and C, and so. If you look at data from the Minnesota Department of Health, the age-adjusted incidence for chronic HBV among Somalis is about 10-fold higher than non-Somalis. For HCV, it's about 3-fold higher. And among Black Minnesotans in general, 3.7 fold higher than the white and non-Hispanic Minnesotans. So this is a significant risk factor. This is an at-risk patient population. And so here are some initial studies, here at Mayo Clinic that were published back in 2012, looked at really the incidence through some community-based screening efforts, looking at the incidence and the prevalence of hepatitis B and C. And you could see the numbers there. There was a high prevalence of both Hep B and C in the immigrant Somali community. A follow-up study to that, almost 10 years later, was published and kind of confirmed those findings that really chronic HBV and HCV are major risk factors for liver disease and for liver disease and HCC among Somali immigrants. And so this is a net risk population here that we have in our catchment area, and that develops HCC in that context. So I say that because this is a patient and at-risk population that, based on some of the data we have right now, it's emerging. But at least there's a suggestion that a lot of them who develop HCC in the background of hepatitis B may actually derive the most benefit from these immunotherapy based treatments. But they are not necessarily represented in those immunotherapy trials, and that's kind of where we need to do a lot of the work. So I'll kind of transition here to the cancer clinical trial disparities and some of the barriers to accrual. So we talked about HCC, and that's applicable to a number of other cancers, the disparities in the clinical trial participation. And I'm going to just, I'm highlighting here a couple. You could see, for example, here that you look at pancreatic cancer, African American Black patients have the highest incidence and mortality from pancreatic cancer, but probably have the lowest accrual of all pancreatic cancer clinical trials. You look at prostate cancer, the same phenomenon. They are not represented, and they have the highest mortality. Black men, but they're not represented in the trials. And you can see here an example of a trial that a prostate cancer trial that did not enroll or include a lot of African American patients, yet they have the highest incidence and mortality. So that's kind of a disconnect there. That's a disconnect that we need to. That's why this is important to address this. So how do we do it? Looking at the barriers to clinical trial accrual, I think a lot of them are somewhat linked to the reasons why we have cancer health disparities in general, and I think I highlighted them at the beginning of the talk. But they range from structural, clinical, physician related or patient related, barriers. So from a structural standpoint, from a clinical trial standpoint, there may be a lack of on-site trial availability. A lot of the clinical trials are housed at academic centers. That's 80% of the trials are actually academic centers. But these at-risk population, 80% of them actually are in communities, are in the community, and not in communities where they have academic access to these academic facilities. So there's already a disconnect there. So lack of on-site trial availability, and then beyond that, you look at eligibility exclusion criterion. A lot of the trial are very restrictive. They have criteria that disproportionately exclude patients from these at-risk community as these at-risk populations. So that again, these are examples of structural barriers that I think are contributing to the limited accrual of these patient populations. And then there are clinical factors, the disease, the stage, when they're diagnosed, physician-related barriers, lack of knowledge regarding trial availability. Like I said, a lot of the providers that take care of these patients are actually in the community, not at academic centers. So they may not be aware of clinical trials. And then, they may not have enough time and resources to really take the time and review and take that extra effort that it takes to really see if a patient is a trial candidate. There's also physician bias. A lot of time, people may look at a patient and say, because of their socioeconomic, psychosocial situation, that they are not a good trial candidate just based on the so-called eye test. When really that may not be true. So a lot of patients are not even offered the opportunity to participate in a trial. And then obviously, lack of workforce diversity. So, to enroll and retain patients in a trial, you need people sometimes that can connect with them culturally, that can relate to them and understand them in the context of their, psychosocial environment, and that requires really a diverse workforce. And then at the patient level, health literacy is one reason patients are not aware, they're not educated about research and clinical trials. They may have misconceptions for historical reasons. I mentioned earlier some of these social determinants of health, that kind of prevent them from even getting to the having access to these academic centers, and let alone to trials. There's a distrust component, again, because of historical reasons. And then resources, financial resources. It takes logistically and financially a lot of effort to be able to participate in a trial, and from transportation, lodging, and even copay if you have to go to an out of network facility to participate in a trial. So these are all barriers. I'm listing here just the main, but there are a lot more that fall in each of these categories. So, I want to spend some time on something, because I mean, as you can see, it's a multi-level barriers, and I want to focus some of it which you may have control on, and some of which you may not have control because they have to be fixed at the federal institutional levels. But at a physician level, I think there's one thing that if you could take away from this, is that we have to offer patients the opportunity. If a patient is not aware, or offer that opportunity, they're never going to enroll in the trial. So that's at least something that we as providers have in our control. And I'm highlighting here a study by Unger al that was published a couple of years ago, showing that when they looked at investigators and referring physicians, and the reasons why people enroll or not enroll, you could see here that when patients were offered, were asked to participate in the clinical trial, 55%, over half of them, actually enrolled. I'm talking about minority patients. So if given the opportunity, they are not less likely to agree to participate like most people may think. So there's a bias there that needs to be um, addressed, and this study kind of shows that. It also highlights why, it shows here that 85% of patients were prevented from participating because of structural and clinical barriers, some of which I already kind of alluded to. And so this is very important, at least to at least give patients an opportunity. We as physicians, investigators, are the gatekeepers, to clinical trial participation. So we need to do our part here. Um, this is another study that looked at bias and stereotyping among research clinical professionals, and from a perspective of recruiting minorities. And they conducted about 90 or so interviews at 5 different cancer centers throughout the U.S., which are listed there. And the themes that emerged, were that people perceived recruitment to be challenging because of new knowledge, language barriers. Um, they weren't perceived, minority patients were not perceived to be ideal study candidates due to issues of compliance and adherence. Some stereotypes related to the race and ethnicity, and from certain backgrounds. And so mistrust, lack of interest, and so all of these reasons, kind of created perceptions that led to providers withholding clinical trial opportunities from potential minority candidates. So there's a really an unconscious bias that's happening at the provider level that needs to be addressed. So how do we address this? What are some resources and strategies? It's by no means a comprehensive list, but hopefully some resources and some guidance. Again, at the structural level, availability of the trials. I think if you're a site, and I'm going to go into it in the next few slides, it has to be a site self-assessment to see what are we able to do, what is our capacity, where do we need to improve. So strategies have to be site specific, and then that starts with the site self-assessment, looking at your catchment area, looking at the at-risk populations, and so recruitment. You also have to do looking at that. You have a diversity plan. How many patients from these at-risk population do we need to enroll? From a clinical standpoint, look at eligibility criteria, loosen some of these eligibility criteria, and there's guidance on that. A lot of people use templated criteria that may not be relevant. HIV 10, 20 years ago may have been an important criteria, but today may not be, because we can live and control it. So there's some comorbidities that are experienced by minority populations that could disproportionately exclude them from clinical trials. So these need to be loosened, they need to be reviewed, and make sure that they're really truly good eligibility criteria. The physician level, like I mentioned, screening for trials, giving an opportunity to patients. There's an unconscious bias and there's implicit bias training available, and I'm going to highlight that in the next few slides. Referring to academic institutions, taking advantage of clinical trial matching tools, and at the patient level, increasing awareness and knowledge about clinical trials and the importance of participating in clinical trials, because in my opinion, really the clinical trial is the best treatment that a cancer patient can get. So I think they have to be offered that opportunity. Looking at language barriers, facilitating the process for patients from minority population, translating informed consent, in their language. There's a short form for that. And then lastly, looking at access, you have to get the patients in the door first, but also retaining them on the trial is a whole separate issue. And for that, you need clinical trial navigators that are going to really help the patient throughout that journey. And there's a whole financial piece too, and different programs, social workers, depending on where you are, your institution, and even at the national level, there are programs through different foundations, to the American Cancer Society, that you can leverage to really ensure that patients are not just enrolled, but also retained on the trials. So I'm going to highlight here, like I mentioned, there are a lot of resources, but I'm going to highlight here what I feel is probably one of the best resources out there. And it's really a collaborative work between ASCO and ACCC. That's the Association of Community Cancer Centers, and they really looked, it was a group of experts, people, clinicians, researchers, patient advocates, put their heads together and produced the first research statement that highlights recommendations for actions that will increase racial and ethnic diversity for in cancer clinical trials, no matter where the patient receives, their care. So the statement covers specific domain. I think there's 6 domains: access to clinical trials, equity focused design, partnerships, education and training, investment in equity, diverse and inclusion, EDI, and sharing data and strategies. So there are 2 great tools that I would encourage every site to at least explore. The site self-assessment, I think it really helps teams identify potential opportunities and specific strategy to improve EDI in clinical trials, while also doing an internal review of their existing policies, programs, and procedures. And that's published out there on their website. There's also the related to the bias, implicit bias training. There's the Just Ask, increasing diversity in clinical research, and that's for opportunities to change, at the individual level, at the provider level, and so those are all great resources that I think I would encourage you to read. Read the statement, the published statement, the research statement. Take that, site self-assessment to see where you stand, what are the opportunities for improvement, and strategize. And then have your providers complete the Just Ask implicit bias training program. I think those are some of the resources. I think if you want to do something, you may not have control over everything, but I think that's a great place to start. And again, I'm going to highlight this implicit bias training program because I took it myself. I had some of my colleagues take it, and I think it may be a game changer for a lot of providers out there to just look at things differently. So, over the last few minutes here, I'm going to highlight some resources. They are by no means comprehensive, but just to give examples of what's out there and what you could be used. When it comes to clinical trial matching, there are a lot of efforts in this space, including AI, artificial intelligence. But I'm just listing here a few websites that you may want to, explore, and that may help, connect your patients with different trials. The clinicaltrials.gov website is not the most patient-friendly or user-friendly website, but these are some alternatives, and I'm sure there are a lot more out there. Um, Also, for patients, you encounter patients that are hearing about clinical trials for the first time and have doubts, skepticism about it, and have connected patients, for example, to these resources, a peer clinical trial support program where they may get in touch directly with a patient from the same racial ethnic background that's participated, in a trial, and what the experience was, and sometimes that goes a long way to hear from another patient from your, in your same situation or similar situation that's gone walked that journey that you're about to walk. And so that's something that's out there that I found helpful in certain situations. From an access and financial standpoint, there are a number of programs. There's a co-pay relief program. There are a number of programs through the American Cancer Society, the Hope Lodge, to kind of facilitate, access, and mitigate some of the financial toxicity that may come with participation in a clinical trial. And last but most importantly, connecting with the community. And by connecting, I mean establishing a constant presence in the community. You don't want to just come to patients or community to enroll them in clinical trials when you are barely there. So that exacerbates and the distrust between academic centers and communities. So you really want to establish a constant presence, be involved, health fairs, campaigns, around, what's happening in the community. I'm just highlighting here a few of the, community outreach, events we participate in from with the Somali community that I mentioned. Really, we're intentionally trying to target because they are an at-risk population that's not represented in our immunotherapy trials. But you have to get to know them. You need to know when Somali Independence Day is, and kind of create events around that time. And so that's very, very important, not just to establish that trust, but also when it comes to even designing studies, it has to be co-created with the communities. We work closely with the Somali Health Advisory Committee here in Rochester and Minnesota, to plan and design these studies, and you'd be surprised how much you can learn about how to communicate with a community. So it has to be co-created, co-designed, co-informed by the communities, because at the end, you hope that it will benefit them. So I'll wrap things up here. Kind of some key takeaways. As you could see from this presentation, cancer health disparities come from, it's not a one size fits all. It's like there's really a complex multifactorial sets of influences, some of which are modifiable, some of which are not. And so it's really important to tease out, depending on your patient population, your community, which interventions are the best, and tailor that to your specific community, their specific etiological complexity. Culturally tailored community outreach, education, engagement can be helpful in terms of mitigating some of these community and patient level barriers to access and accrue to clinical trials. And like I said, it has to be a partnership. You have to co-create with the communities that you're hoping to target. Unconscious bias, I think that's one thing that as providers, if there's one thing you could take away from this, is really think twice again. Think about how much of this is happening in your practice. And I'm sure you could think of colleagues, yourself, patients that you've said, this is not a good clinical trial candidate, just based on that eye test. But if the patients are not asked, if they're not offered that opportunity, they will never be able to enroll. So as you could see, a wide range of it's very multi-level barriers, and there are a wide range of resources that could help you, depending on what your site specific, your institution specific, your community specific barriers are. So I want to end here. I think the number one way you can impact diversity, access, and inclusion to clinical trials is to ask your patient to consider a trial. talked about a lot here, but it's a broad, complicated topics with so many nuances. But the reality is that there must be kind of a top-down, bottom-up, peer-to-peer community engagement and involvement, and really a super dimensional approach to fixing this problem. And so focus on what you can do now. It could be down to think about all of the barriers, and not even know where to start, but think about what you could do now, tomorrow, kind of on a step by step, and realize that behind all of these statistics, are real human beings, whose lives depend on what we do individually and collectively. So it always seems impossible, daunting, but until it's done. And I think the first step is at least to start. So thank you for your attention, and I hope you learned something here, and I hope based on this, you change the way you look at disparities in clinical trial participation, and hopefully come up with an action plan. Thank you.
Dr. Fancoa, thank you. You are so committed to improving equitable access to care for all cancer patients, including the underserved and at-risk populations. We are so grateful that you shared your knowledge and passion with us today. This concludes our incredibly motivating afternoon together with Global Liver Institute and our Liver Cancers Department at Innovating and Advancing Research in Liver Cancers webinar. We hope you found immense value in the knowledge shared today by our wonderful and esteemed speakers. Thank you so much for joining us. To help you on your continued learning journey, we will be sharing today's recording on GLI's YouTube channel, as well as educational and patient resources that can be found on our website and social media platforms. Be sure to visit globalliver.org and sign up for our newsletter and connect with us on social media. And before we part, I would like to again thank ASI for their sponsorship of today's webinar and supporting the liver community in such impactful ways. I also want to express my deepest gratitude again to all of the speakers for their insightful presentations and thought-provoking discussions. Your expertise and passion have truly enriched our understanding of the field of liver cancers and have inspired us to advocate and learn. On behalf of Global Liver Institute, have a great afternoon, and thank you for joining us today.